This is the Health and Politics Podcast. Prevention is the new cure.
And that's with former ministers Steve Brine and myself, James Bethell. Steve, how are you?
I'm very well, thank you, James. Sun is shining again in England. I mean, what's next?
Daffodils, yep.
I know. Listen, I've made it back from North Macedonia via Berlin last week, because for those who weren't listening last week, James was in Blackpool and I was in the Balkans. And did you have a nice time in Blackpool, by the way, James?
Listen, it's really humbling. It is a community of 177,000 people who face huge challenges. And what are we doing as a society to help them? Not much, Steve. It's difficult. I mean, I'll talk about it another time, but when I asked the question, what's really working here in Blackpool to make a change to this community, there was not a lot of clear answers.
Yeah. Can I just have a rant? So I was ranting on my way back to myself. You know how you do when I was going through airports. I had to fly from Skopje in North Macedonia, where I was last week, via Berlin back to London. And I had to show my passport 4 times in Berlin airport. Can I just say, including to buy some chocolate for the children, which particularly irritated me. And there has to be a better way at airports. So Berlin Airport, which is a pretty, let's face it, Brandenburg Airport, pretty big airport. I'm sure you've been there.
Yep.
No airside transfer at all. So you literally had to go back out and start as if you were coming to the airport in a taxi. That irritated me. And showing my passport to buy some chocky really irritated me. So yeah, Steve's rant.
There we go. Well, I take a large paracetamol with a large amount of codeine as a when I travel, in order to smooth the edges of those kinds of experiences. So maybe that's what we're going to have lunch today, Steve. Maybe I'll bring with me a pack of super paracetamol to get you through your traveling angst.
So, well, apparently we're going to see each other in the real world today, which is quite something, isn't it? Just one other thing that's been happening since I last saw you, James. I've been doing some work this week on Parkinson's disease with a client of mine in my commercial life. And my father died with Parkinson's, as I mentioned, I think, before. I just want to give a plug to another podcast, which may seem strange, but there are others out there, believe it or not. It's this really good one. Have you ever heard of the podcast called Movers and Shakers?
I have, yeah, with Rory Cellan-Jones.
So Rory Cellan-Jones is on it, a lady called Gillian Lacey-Solomon, who sort of tends to lead on it, and Mark Mardell, who is obviously another former BBC journalist, and a chap called Paul Mayhew Archer, who wrote The Vicar of Dibley, and Jeremy Paxman. Yeah, Jeremy Paxman was part of the original Movers and Shakers, and I think he's not very well at all at the moment. And they sort of gather in a Notting Hill pub every time they do the podcast, and they discuss the realities of life with parks, and then they do campaigns, and it's just a really, really good podcast and really interesting, and I think people might want to check it out.
The key thing to know is that the people who know the most about Parkinson's disease are the people with Parkinson's disease.
Yeah.
And that podcast, and similar things like it, provides such intelligence and thoughtfulness and help to people who have got that. And it's really powerful. Yeah, no, a big shout out to Rory and the gang for doing what they're doing.
Yeah. Thanks for listening. This is Health and Politics Podcast. It's called Prevention is the New Cure. We are on, believe it or not, this is episode 89 of this podcast. And we are 2 former ministers, and we try and give insights into what's going on in health news and politics in the last week. And look ahead. I mean, that's what we're about. Look ahead. But we try and do that with the insight of the things that we've seen inside government. And next week, James, we're going to see each other in the real world today for lunch. And then we're also going to be out doing a live episode next week, aren't we?
At Rewired. Rewired is a great conference. It's going to be lots of fun health tech people, some big health challenges. We've got a good super guest. We'll announce that nearer the time. And I'm really looking forward to it. Lunch in Birmingham.
Yeah. So we're going to be at the NEC next Wednesday afternoon, and we'll put the episode out on Thursday. So, bit of listener feedback for us, James. This is from Upkar Jeeta, who's the head of mental health transformation at an NHS trust in the Midlands. And the message says, I want to take a moment to thank you for your podcast, which I've been following avidly. I absolutely agree with your vision. The NHS needs a radical shift from treating disease to prioritising prevention. The comment in episode 85, good health doesn't happen in hospitals, remember that, really resonated with me. And I actually quoted it during a recent presentation about neighbourhood mental health centres. So that's nice, isn't it?
Well, I think neighbourhood mental health centres are themselves a nice thing. So thank you very much, Upkar, for all the work that you're doing.
Yeah, and this was an interesting message from an organisation called Fresh and Balance in the northeast of England, which is a smoking cessation movement, which I dealt with when I was the minister, and they helped me write the smoke-free plan that I put. They say this: evidence-led media campaigns based on insight that are evaluated can definitely play a vital role in public health. In the Northeast, we have significant experience in this, and 21 years plus of delivering effective campaigns on smoking is one of the key reasons why our region has achieved the biggest drop of smoking of all the English regions. We need to give many people as many ops as possible to give quitting a go. And that was off the back of our conversation about No Smoking Day last week.
Yes.
So thank you to Fresh for that comment. And I will spare your blushes, James, with just one other I wanted to mention. We discussed last week that your decision to not seek the lifeboat, and obviously as a hereditary peer, you are leaving the House of Lords very shortly. Lots and lots of feedback on that on our social media. This one pretty much sums it up. James, I hope your influence only grows from here and that your vision of a prevention-first approach to the nation's health becomes a reality. So there you go.
Steve, that's very touching of you to sneak that in. Thank you. That is my intention. Listen, we're at a remarkable time in history where there's so much new technology, so much more ambition for healthier lives. I've enjoyed the House of Lords, but it's not the place where we're going to win the prevention battle. And I've just got a huge appetite for doing that in other ways. So yeah, don't worry, I'm not going anywhere.
Excellent. Well, I hope not. So we've got quite a lot coming up today. We're going to start with a story that is genuinely frightening and leading the news, a meningitis outbreak that's killed some young people in Kent. And we're going to look at the system that possibly took too long to warn parents. So we're going to start the show there.
Then we're going to ask whether the government's own science minister has just made the most important speech in health policy in years, and whether anyone was actually listening.
After that, we're going to look at a blood test that was supposed to revolutionize cancer detection, except there's a problem. So we're going to unpack that.
Yeah. And then something we promised last week to come back to and do justice, AI in the NHS. Key question. I'm going to be spending a lot of my time in the next year on this. We've got a brilliant guest, Jenny Shand, who's going to tell us what's actually happening on the ground and to cut through both some of the hype and also some of the naysayers.
Yeah, look forward to that. And then we're going to finish with a story about Parkrun, because they've hit 10 million participants, James. Did you know that?
And I'm going to ask you how you did in your last Parkrun.
Spoiler alert.
How's that going to go?
Yeah. What could possibly go wrong? So thanks for listening to the show. Please hit subscribe as you do. Then you'll get a brand new episode each week as it lands. And you can even WhatsApp us. Did you know that, James? You can WhatsApp us. If you add a voice note, we can play it in on a future episode. Our WhatsApp number is 0333 404 6507. Right, back to the top. Okay, deep breath. Very sad story. A meningitis B outbreak has killed 2 young people in Kent. Of course, it's all over the news. And the central question is not whether the disease is dangerous. Clearly, that is self-evident. It's whether the warning system worked. So evidence is mounting that the public health alert was maybe delayed. The information reached parents possibly too late. There is now, of course, a furious public debate about who we vaccinate, why we leave some people out, and how/if we should do a catch-up program. The Royal Society of Public Health is also moving into this area of access to vaccines, and James, you're very much part of that. But I thought we should start the show today talking about meningitis, and I think we should just say at the very, very start, obviously, we send our heartfelt condolences to the family and the friends of those who've lost their lives here. But we have to stress, this is not a medical podcast run by clinicians. We are not clinicians. We don't give medical advice. If you're worried at all by any of the symptoms that you have, there's a wealth of information out there online. I would suggest the charity Meningitis Now is a very good place to start, but you should ultimately call 111 or 999 if you're worried.
Steve, thanks for raising this, and I thought you just put that very well. My fear of this outbreak is that it's an augur of what we've got to look forward to for the next 10 years. In other words, the specifics of this outbreak are contested. Did they move too slowly? Probably, but this wasn't an egregious mistake. Are there vaccine gaps? Yes, there are, but that's not the reason why you might have an outbreak here or there. But what we do have is a pattern right across the country of big gaps in coverage, either through restricted coverage because the authorities have decided that only certain age groups or certain demographics are going to get vaccines, and we have a very, very conservative mandate on vaccine. The access is terrible. I've got 4 children. Trying to keep up on their vaccines is a nightmare, and I'm a flipping former health minister. I can hardly keep up.
It's really hard, isn't it?
And a lot of people trying to run the vaccine program through GPs and GP practices feels very old-fashioned. It's not how we did it in the pandemic for that reason. We know exactly how to have effective rolling out of vaccine campaigns. By the way, we're also very good at speed cameras and some other basic bits of state infrastructure. The fact that we're behind on all 14 of the basic UN vaccines is a national disgrace. And therefore, we're going to have to live with outbreaks like this all the time. And it'll be measles one day and RSV another. And that is just no way to run a modern country. It's bad for productivity, bad for people's long-term health, bad for the NHS, bad for the taxpayer. And it frustrates the hell out of me, Steve, if you hadn't noticed. I'm
Yeah.
just worried that this is literally going to be the drumbeat of the British health system for the foreseeable future unless we get a grip of it.
Yeah, and I think parents, including us, are worried. I mean, I was out for dinner with an old school friend last night who was showing me messages between him and his wife as to, what was available in Boots where they
I know.
live or Superdrug where they live, and people are understandably concerned. But I think let's just sort of go back to sort of the facts as where we are. Look, this is very serious, of course, but it's still a cluster, not a national wave, and I think
Yep.
it's important to make that point. So the outbreak in Kent is real, it's fast moving, and of course it's tragic and 2 deaths, mostly among young people. It's been described as unprecedented in speed and clustering by some of the clinicians this week. But I think the uncomfortable truth is that public messaging on this walks a real tightrope because nationally, Men B, and this is the strain that we're dealing with here, is very rare. So we're talking hundreds of cases a year, not thousands. So I think, locally, it's severe. Nationally, it's still low in incidence. And I think that nuance often gets lost in the headlines. And we've seen some screaming headlines this week, which is no doubt driving that fear. I think the real vulnerability gap is policy created, as you're alluding to, James. I think that's probably the biggest unsaid here. The truth is the Men B vaccine has been available on the NHS, but only for babies since 2015. And that means, so at the end of the coalition, basically, so that means that most teenagers and all current university students, therefore, are
Yep.
unvaccinated because when the JCVI, which stands for the Joint Committee on Vaccination and Immunisation, when they bought in that, they judged that a catch-up program was not cost-effective. And I slightly wince on that because, of course, it's highly cost-effective if you're the one affected. But the group now most affected, so teens and young adults in close contact settings, sharing drinks, maybe sharing vapes, which, of course, has been discussed this week, they're the exact cohort that policy chose not to vaccinate. And that's where we are now. So I suppose the question is, was that the right decision? And then what are we now going to do about the catch up for those who are going into secondary education and ultimately then college and then university? Because of course they wouldn't have been vaccinated as babies. That's the question, isn't it?
Well, you're absolutely right. And JCVI did answer the question, but the criteria was completely wrong. It's been wrong for a while and we need to change it. And the criteria is based on hospital admissions. In other words, it's a producer-led criteria that means that we have vaccines in order to stop people from troubling hospitals with turning up and wasting their time. That is not a modern, sensible, human, credible criteria. It desperately needs to change. It needs to be much more reflective of damage done to people's long-term health, their communities, to the productivity of the nation, and to the subsequent cost in welfare and long-term workforce productivity of having these diseases spreaded around. And of course, there will be a short-term cost to this as we do various catch-ups and as we extend the range of the mandates. And the NHS should rightly bear those costs because we socialise this kind of preventative public health quite rightly, like every other country does. But that cost is going to be minimal compared to the savings. It's the most clear-cut and obvious application of the prevention principle in modern health. And I just wish ministers would get a grip of this and start a honest conversation. For instance, COVID vaccines at the moment, only for 85-year-olds? I mean, really? Does that make any sense given everything we know about long COVID and the long-term impact of COVID on brain health in your later years? There's a whole ton of vaccines that should have a much, much wider reach and criteria, if only we would apply sensible, thoughtful economics to the whole thing. So that JCVI point you mentioned is the key one, I think.
Yeah, and I think vaccination is not a clean solution, and I think officials know it from the UK Health Security Agency. So they're cautious about promising vaccines as being the answer because the MenB vaccine, it doesn't cover all the strains. I'll touch on that in a second. It doesn't stop transmission. Sounds familiar, of course, to COVID days. They take weeks to actually work, and they wane over time. So even a rapid mass vaccination campaign wouldn't stop this outbreak in
Yes,
real time at the
I
moment, which
agree with
is
you on that.
why which is why the immediate response that you're seeing in Kent, where you're seeing young people queuing up in masks, again, very familiar, is about antibiotics, it's about very targeted vaccination, and it's about contact tracing, which I know you have
Yes.
lots of experience of. But just going back to your point about vaccines and availability thereof. So meningitis, of course, there are different strains. There's Men-B, which is what we're talking about here, which is rare but can be deadly. And then there's ACY. So the meningitis ACYW vaccine, that is offered to teenagers, so not just the babies cohort. So they're covered for that big if they've taken it. But rates of that, take up of that was 85% before the pandemic. It's now dropped to 75%. So even where we have government funded,
Yeah.
JCVI agreed vaccination rollout programs, the numbers are going in the wrong direction.
Yeah.
And I just wonder, is this an example where we'll see Wes Streeting as a Secretary of State produce a more muscular interventionist Secretary of State line with his gathering of so much policy and power into the Department of Health? Or is he still just going to step back in a way that we've seen from lots of Conservative Secretaries of State? And I don't know the answer to that at the moment. I think he's Thursday, as we record this, I think he's visiting a vaccination clinic or a medical clinic in Kent today. But it'd be interesting to hear more from him because what he said in the House earlier this week was sort of a classic Secretary of State incident response, which you can't blame him for. Of course, he had to say something. But I'm not sure that he sort of set out a longer term vaccination strategy, which is probably what we need to hear from him.
Well, he did say quite pointedly that he was going to rewrite the one that was done in 2023. The one in 2023 was a complete cut and paste job from the previous one. It was very uninspiring document, frankly. I know work went into it, and the officials involved were doing their best, but honestly, it's and year 9. So I've got a kid in year 9 at the moment. 2022 vaccination rates were 68%. I mean, like 68% in year 9. So it's going down year by year. Listen, we know how to do this. This is not one of those, the application of AI in healthcare, quite complicated, controversial. I don't think we know what the answer is. On this one, we do. And we have done it before. And we just need to focus on it. Steve, you're putting the spotlight on Wes Streeting. I don't think that's a bad thing. We should always keep ministers under pressure. But this really should be led from clinicians. And I'm just not hearing, I'm not hearing senior clinicians, either in post, out of post, on the TV, whoever, taking a strong lead on this. But parents and taxpayers and those who are affected by these viruses, they care about it a huge amount. This is one of those examples where there's a bad disconnect between the leadership of our health, the politicians and the senior clinicians, and the public. And you can be dismissive if you like and just brush off what the public thinks and say that they don't really have any agency in this because they lack specialist knowledge. I don't think they're going to buy it for long. And when we look at the corrosive effect of these incidents on the long-term reputation of the NHS, I bet we point to this incident as being an example of where the leadership and the people are completely out of sync with each other.
Yeah, well, there was a big piece this week from Health Watch, and no wonder the government are abolishing Health Watch if they keep coming out with things like this, saying that
Yes.
people are increasingly giving up on the NHS and just basically using their savings to pay their way out of it when they need anything done because it's not there for them. But maybe this is another example. Pharmacies say that they're completely overwhelmed with people seeking advice about, as are private clinics, about MenB vaccines. Just finally on this, I mentioned COVID a few times. We should be absolutely clear. This is not COVID. This is not a respiratory illness. This is passed by saliva, very, very close contact between, babies or young people. But I think the reality of this, where there is a COVID echo, if you like, is that the anxiety that many young people, and this cohort that are now at university, of course, were at secondary school during COVID, massively formative years. So their anxiety may not be totally based in reality, people living miles away from the Kent epicenter of this outbreak, but I think it's understandable after what they went through in COVID. And I wonder sometimes whether this is the real long COVID. I have an 18-year-old at home who is absolutely full of health anxiety about this.
Right.
And I think that's the long tail of this in some ways. And just the other point, just to make, if I had a look this morning, James, at the website, at the homepage of the Department of Health and Social Care, NHS England, and the NHS's own website itself, not a single mention of this or the issue or the advice to parents who are worried. Sorry, NHS department, not good enough. That needs to be front and center because that is the issue that people are concerned about right now. Shall we move on and talk about Patrick Vallance? Over to you.
Well, Patrick Vallance, he's a great hero of our times. He was a leading figure as the senior science advisor during COVID. I dealt with him the whole time. Very, very thoughtful. Commercial. He's had a big research job in a big pharma, so he knows how the industry works. But also a proper scientist and, apex predator alpha individual who people really listen to. And we're lucky as a country to have someone like Patrick at the top. And he's taken a much bigger and broader role in the current administration as a minister. I mean, it does make me laugh, Steve. I got it. He was, as an official, he was pretty dismissive of ministers. Now he's a minister.
Yes.
It's funny seeing him having to deal with trying to get things done in the world of politics. There's a German word for it. Is it Schadenfreude or something?
Schadenfreude, yeah. So
every time I see him, I
what's
can't
Patrick
help.
up to? Because he's doing a lecture this week or something, isn't he? The
Yes,
Nuffield Department.
That's right. So he's doing the Nuffield Department of Primary Care Health Sciences annual lecture at Oxford Union. So this is a big deal showcase lecture. And I am really pleased that he has chosen to do it on health and wealth. In other words, he's going to argue that we have made massive progress beating a lot of conditions that used to kill millions, particularly things like cancer and heart disease. Not beating them, but making big progress.
Yeah.
But on the current crop of chronic diseases, obesity, mental health, musculoskeletal, we're really not making any progress, and we're stuck with an organization that's really designed around cure rather than prevention. So he's going to make the case for growth strategy. We've had one before. It's the Life Sciences Sector Plan and the 10-year plan. They are meant to be growth strategies, but the implementation on both of them is struggling. So this is, I think, a pitch to the Treasury directly to say health can be a growth phenomenon. It can be a supply side support for the economy. So let's please treat it as such and invest and prioritize prevention. So I am thrilled to being there. I am hopeful that this will be a pivotal moment for the agenda that we both are committed to.
Yeah, and I think what he'll probably do, knowing him as we do, is that he'll argue that science has got to sit alongside economics at the heart of policy. And so every policy area has got a science tech dimension. And it'll be interesting to see whether that flows over into the Rewired Health Tech event that we're at next week. But why that worries me, James, in that...
Sorry, Steve, do you mind if I interrupt? So he will do that a bit. But actually, the heartening thing is that there is a showcase event beforehand, and it's all of our friends from the prevention space. I think it's Mums with Lungs and ASH and the upstream prevention campaigns and charities. So that's unusual to have those campaigners showcased in an academic environment like that. So it's really encouraging.
Yeah, no, all I was just going to say is all that worries me when you say about, it's a pitch to Treasury is that when ministers make public speeches that are pitches to their own Treasury, that always worries me. Like when I felt I had to do that as a minister, it was because the channel between me and the department and the Treasury wasn't where I needed it to be.
Yeah,
and I always think that the government, but surely government should be much, much more coherent and have a growth strategy. I know how naive of me, but they should surely have a growth strategy, which is the heart of what they're doing. That should live with the Treasury, and a growth strategy has got to be more than, let's just be more friendly with the European Union, as we heard from Rachel Reeves in her Mace lecture this week. And the science minister should surely be on message, and part of that, he should be on the same page as that, not making public pleas to the Treasury. I mean, how naive am I?
I think you're very naive, Steve.
Sweet.
We're friends. I can be direct with you.
Yes.
The Treasury are deeply sceptical of the idea that health can ever be anything more than just a sunk cost, just a big hole to pour money into. And it is an ongoing struggle to try to get them to believe that this money could actually have a payback in terms of healthier workforce, lower welfare, and a growth agenda. By doing this speech, he's had to clear it with the Treasury before giving it. And therefore, he's not only on a podium sort of talking to Treasury, he's also clearing his lines and making sure that the Treasury have read the speech in advance. So it is a part of the process of communication. And in the background, there is a ton of work being done on this. I think that they are struggling with it. I don't think that they've made a lot of progress. But I'm really chuffed that someone like Patrick Vallance, who's got the ear of Keir Starmer, who's well in with Rachel Reeves, who's in the top tier, in crowd player, is devoting time and energy to this. And even if the current Treasury and the current Downing Street aren't quite there yet, having him advocating is good for us. I mean, it's good for our business, I think.
Listen, we're just going to take a quick break before we come on to the next story. Just before we do, just sort of breaking news, I suppose, as we record this, I see that 6 more meningitis cases, which I presume are Men B, have been confirmed in this Kent outbreak. So, when I think they were briefing out last night, they feel this is contained. And we've been here before, haven't we? Perhaps not. And that's why the advice is that doctors all over England are being told to gen up on the signs and symptoms of meningitis, because of course a lot of the students in Kent will, if my child was at university where this was happening, what would you say to them? You'd say, well, come home.
Yeah.
It's almost Easter, come home early. And of course, by doing that, of course, you then move and potentially move the virus with you. So yeah, 6 more cases. Anyway, we're going to take a quick break. You're listening to Prevention is the New Cure, the Health and Politics podcast, and we'll be right back. Welcome back. Guest time. Prevention is the New Cure, the Health and Politics podcast with myself, Steve Brine, and James Bethell. We're going to talk about AI now, James, aren't we?
We are. And the reason why it's so important is that the future of the NHS depends on AI delivering a big, chunky improvement to productivity so that we can spend some of the savings on infrastructure and neighbourhood health. That is theoretically the big plan that Amanda Pritchard laid out couple of years ago. And I love the ambition, but I think it's quite a good moment just to check in on the reality of it. The House of Lords is running an inquiry on this specifically. They've just started their evidence sessions. And what I got from it was a mixture of excitement and ambition, but also of concern and worry about whether it's actually delivering everything that people wanted from it. So we've asked Jenny Shand to join us. And Jenny is a good friend of the podcast. She is Professor of Applied Health Research at UCL and Director of the NIHR Rapid Service Evaluation Team, and literally the best person in Britain to be answering this question. So, Jenny, can I put you on the spot? From what we know so far from real-world evidence, how is it working with the AI rollout on the front line of the NHS?
Thank you, James. So that's quite a massive topic, isn't it? And hi, everyone. Welcome. So what we have been looking at in my team is the deployment of 2 different kinds of AI tools. So one was around the use of AI in chest x-rays to detect lung cancer. And the second is ambient voice technology. And what we've been doing on the latter, I think, is quite relevant and important here. So we have obviously got a highly ambitious and enthusiastic system who are pulling these technologies and using them at pace. The evidence isn't keeping up, let's be honest. And at the moment, there is suggested evidence that using ambient voice technology in a consultation could potentially reduce documentation burden. So that's an output, and that's important. There is, at the moment, very little evidence that translates into a productivity gain for the system. And I think that's where we need to proceed with caution. So where do we have evidence that we are able to unlock these productivity gains? And where is there more that needs to be learned? A critical part on this is, as you've flagged, the implementation and the deployment of these technologies. And that's certainly what we found in our AI for chest diagnostics, is that actually the deployment really matters. So you can have a technology that works, you can have a technology that is regulated and proven, but how is it used in practice? How is it used in that patient pathway really matters. And it's really difficult to unlock value if you implement it in different ways. So I think at the moment, my sort of optimism bias is to say, that's great. There is a pull from the system and that really matters. Clinicians find this useful. It might make their days easier. But let's go in with our eyes open about where is that actually an evidence base that this then unlocks capacity for the system or enables us to see more patients or enables us to have staff that are able to work more consistently, that are happier, that we have better staff retention, etc. The evidence is on that at the moment.
But Jenny, I am totally confused. We are living in a remarkable revolution. There's a ton of money going into health and AI. And I personally used Claude to plan the Bethell family Christmas. I've got 4 children at 4 different schools and a wife who lives overseas. And getting us all into a single point is quite complicated. But Claude made it much easier. And it's really, really demonstrated how the productivity of the Bethell family can be improved. Surely this is a complete walkover for the NHS. The AI is going to solve all our problems, isn't it?
Well, I guess it comes back to, what are you measuring? So if you just measure the moment that you're using Claude to schedule the Bethel diary, that's one piece. How many adjustments did you need to make afterwards? And what did you do with the time you might have otherwise spent looking at all of the Bethel diaries to try and coordinate your Christmas plans? And that's what we've got less insight on. So time is not always money. If you are freeing up that time, how are you using that time? And if you're using it to read a book, well, that's great, might give you a good day. In a clinical context, if you're using that time to see more patients, that is a productivity gain. But if you're using that time to work less overtime, that's actually just us trying to make sure that workloads are more manageable. It's not going to get us more productivity in the system. Does that make sense?
It does. But are you therefore seeing either a qualitative improvement and when I see my doctor and he'd introduced Heidi as his scribe, I can't tell you, he was so happy that he wasn't writing out notes. And his treatment of my knee was better than when he had looked at the knee before, because he wasn't trying to write it all down at the same time. Does that mean that I might get better consultations and not have to go and see him more often? Or does it just mean he's happier and might take fewer days off sick?
I mean, it could be both, right? So what we have seen, we looked at what is the published evidence to date, and there is 22 papers that have evaluated ambient voice technology rollout so far. That is across a global market, predominantly in the US, which is where things moved at pace quicker than here in the UK. And we had quite a lot of qualitative evidence of clinicians reporting, I felt I was able to spend more time with my patient. I felt that I had a better interaction with them. I felt less distracted by looking at the screen and typing it. And there was a little bit of qualitative evidence from patients where they reported the same. What we don't yet know is, does the letter that comes out of that AI scribe consultation actually give you better information as a patient, because it's able to tailor the conversation, it's able to tailor the content, it's able to more quickly point you to other resources that helps you understand what might my recovery rates be, what might my questions be about side effects, what might important changes be that I need to do. So we don't yet know, does that actually activate patients in a different way because they're able to access their content better? We don't yet know, does actually this lead to, yes, the consultants are really happy using it and they feel that it's saving them time in their day, but we haven't yet really looked at those other unintended consequences. So as I said, the risk that you take, so the consultant is still responsible for what gets documented in the notes. Therefore, you do need to do that quality check. We know that people are worried about hallucinations, etc. We know that different dialects are less accurately collected. So we in London have 300 and more languages spoken, and we know that not all tools are great at managing that. We know that when there are multiple voices, it gets more complicated. So if you go to an appointment with a carer or with a family member, it's sometimes harder to untangle that. And what we don't know is, what impact does that have on the overall time saving? So I guess I like to think about it as, time is not always money. That time is saved, and we have got emerging evidence that, yes, documentation burden does reduce by the use of these ambient voice technology tools. But what we don't yet know is, in those different consultations, how is that time then used? And you can see theoretically that in A&E, if there's a queue of patients out the door and you're able to see and process patients quicker, you might see more patients within a slot. That might be true when there's patients out the door. It might not be true at 4 a.m. when there are fewer patients waiting to be seen. If you're in sort of a GP practice or in outpatient clinics, unless you restructure how you schedule those appointments, it's very difficult to say we can get a productivity gain and see more patients. It might be that in your session, you're able to see some patients quicker and therefore spend longer with the more complicated patients that do need longer conversations. The other thing to flag is, it's different in different clinical settings. So the use of ambient voice technology in mental health is emerging at pace, and people are pressing forwards with that. They are highly conversational interactions. They are less about sort of see and treat, update your medical record, prescribe somebody something for their ailment or do a forward referral, they are a little bit more complicated, let's be honest, and what happens in that interaction. And sometimes what we've seen on some of the AI scribes is they therefore sort of think, oh, this is just conversational stuff. This is James, Jenny, and Steve just having a chat about this, and therefore that's not relevant. And actually, the clinicians think that's the most important part of these conversations with some of our fragile patients. And therefore, there is a bit of an update on how do you structure the use of those AI tools so that they do give you high quality documentation of that consultation without having to go back through the whole of the script to pull out what matters. And what we've seen in outpatients is they're highly templating the outputs for those different clinical settings. So what you get in dermatology is very specific, and that is different from what you might get in a diabetes clinic, for example.
Jenny, this is fascinating. I'm still reeling from the Bethell family Christmas brackets made by Claude. I just love only you, James, only you. Jenny, just a couple more things on this. The US physician called Bob Wachter, who Jeremy Hunt, when he was health secretary, commissioned to look at this area of policy, which was obviously there some years ago back then. And I've just been reading bits of his new book called A Giant Leap, which is about AI's impact on healthcare. And his first book was called Digital Doctor, which was more about the digital health record, basically, which obviously wasn't proper transformation. That was very negative about this. He said when he produced that report for the British government that these healthcare innovations don't save the money they're meant to or achieve the results. He called it the productivity paradox. And you've sort of said that a few times. So I just sort of wonder, digitization is essential. We all know that. But the NHS is going about it the wrong way, is what he said then. Overall, what sort of scorecard would you give? Is the NHS now going about it the right way, bearing in mind that Royal Colleges, BMA, the workforce plan that's coming out, they're all talking about, real world people workforce and how we just need more of it. It doesn't feel to me like they got the memo.
I think the important bit is what role does technology play in the patient pathway, and how are we really deliberate about that functionality? So personally, I don't need to be rewatching a video of every meeting I have every day. The technology exists to record every meeting and to document that. That's a bit of a data burden to save all of that. And I think sometimes because the technology is there, we're using it thinking, oh, right, great, we must use that. And that's helpful. It's not always helpful, actually. And sometimes the 5 bullets you write in your pad are equally relevant to how you might action what comes out of that conversation. And I think we have to think about that in our clinical pathways. What's been very strong and reassuring is that the accountability still sits with our professional groups. And I think that's the most important piece. So technology is an enabler, it's a tool, it's not a colleague, and it has to be treated as such and has to be implemented as such. I think the second piece is about how do we get this integration across the patient pathway so that we don't get fragmented about lots of different plasters sort of sticking on to things that aren't quite working in our system, but we think more fundamentally about how do we reshape our workflows and look at the function that technology can have in that. That's where I think it is really exciting, some of this digital triage, some of these different modes of accessing the health system, and I think, the ambitions around a digital hospital, I know people have mixed views on, but for me, let's think about the public and how they engage with different kinds of services.
Absolutely.
There is no wrong door on this. And this enables us to open a lot more doors, to channel people to different forms of support, to actually empower them to be in control of their decision making. We're in a digital world. People will use maybe Claude, maybe ChatGPT to get some understanding of what their health needs are. And we kind of need to be quite dynamic in how we respond to that. So technology is here, but let's use it as a tool, not a colleague. It's certainly in some instances can be a substitution of things that we've done before, but not in all cases. And I think the critical bit is what function does it play in the patient pathway? So we should be product agnostic. And as a sort of independent researcher, that's my most important piece is I'm not here to prove the market value of X product. I'm here to prove that that functionality in the system can be beneficial to the NHS. And I think that's, again, coming back to ambient voice technology. It started as an AI scribe, but where's the real value? Is actually up that pathway chain in digital triage in the first place through to clinical decision making. How can it be a decision aid? Much of medicine is about pattern recognition, and actually large language models are quite good at that. So how do we use that to enable us to be like, oh, have you thought about this? And to be a prompt for our clinicians so that we can get patients access to the right care when they need it.
Brilliant. Jenny, that's fascinating, wasn't it, James? My goodness, Jenny knows a lot about this
totally
subject.
Nailed it.
I thought you'd overhyped Jenny on the introduction, and then I realized that actually we probably underplayed it. Jenny, thank you so much for joining us on the podcast and giving us your insights.
Very kind. Thank you for having me both. Really interesting to have the conversation.
There goes Jenny. She was really fascinating, James, wasn't she? It's interesting to get that independent, non-product view, isn't it?
I know.
Just finish a couple of things before we wrap up this episode, James. We just touched on the Grail blood test, weren't we? So for those who don't know, the Grail Gallery trial, it's this multi-cancer early detection blood test. It was one of the most hyped, interested, watched clinical innovations of probably the last decade. And the NHS has run one of the largest real-world pilots in the world. There's 140,000 participants. And I suppose the promise of Grail, if you want to put it in a nutshell, is that it could detect abnormal DNA signals from more than 50 different cancers using a single draw of blood. Anyway, they brought out their sort of first results, if you like, and I don't think it's exactly what they were hoping for.
No.
It's not a disaster by any stretch, but I don't think it's what they were hoping for. And I just wonder whether we should touch on that briefly before we go to our park run.
It's the most important thing really in the prevention space. So the vision is that these more sensitive tests can spot the cancer fragment shards of the cancer cells in your blood and give a very, very early readout of whether you're carrying cancer. But there are a couple of problems with this. Firstly, you and I are both carrying cancer. We're in our 50s. We're in Cancer Alley. I've probably got a bit of prostate cancer in there somewhere. But there's no need for me to panic about that necessarily. Definitely not to have my prostate taken out. And therefore, having very, very early prediction of something does create a false positive. Now, that in itself is not an entirely bad thing because there are other backup tests you can do, follow-on tests, to figure out whether this is a material diagnosis or whether it's simply a warning that you need to keep an eye on things. So the second problem is that the NHS is not, and frankly, the state of our GP and health system is not very good at risk management. Educated into doing is mainly around much more black and white, red, green traffic lights. You've either got cancer or you haven't. That's a little bit maybe overstating it. But in terms of a sort of collective understanding of risk management, that's not really where the state of our health system is. So there is a big fear about false positives. I personally happen to think I'd prefer to know that I had a little bit of prostate, but just needed to have another prostate test in a year than to not know at all. Secondly, not only is the system not terribly good at handling ambiguity, the test itself doesn't have enough data on it already to be able to say on its own whether something is a material flag or whether it's simply a super early warning. So there is some massive grinding of gears and analysis needed on how we use this kind of interpretation. I fear that this will be perceived as being proof that this kind of early detection stuff is just a waste of resources and potentially compounding problems by putting people into harm by having additional tests. I hope that's not the case. I hope that this is a little fumbling first footstep towards a more sophisticated understanding of risk and how we can catch disease earlier and therefore modify that risk either with treatments or lifestyle changes. Steve, you're looking pensive.
Yeah, I'm pensive about it because I know Harpal Kumar well. He used to run CR UK, who leads Grail, and actually Helen Stokes-Lampard and I had him on the podcast, one of the early ones we did. Yeah, we had him on for one of the early episodes, which you can find on our archive, talking about Grail when it was quite early on. There's quite a few knives out for this.
Yes.
There was a front page of the BMJ August 24, and they had a chalice that was tipped over and blood trickling out of it into a question mark, and it said the holy grail of blood tests, new evidence cast doubt on a much hyped screening tool, which is interesting in itself because that obviously is written by clinicians for clinicians. So there's that. The other thing that concerns me about this, I think you're right. I think it is absolutely wonderful, and it is the holy grail. And I really, really hope it can work because it can detect cancer very early if it works. But when I look back to when I was doing the bowel cancer screening program, the FIT test, the system sort of said to me, "Look, Minister, it's no difficulty sending out the boxes, sending out the kit for the poo in the post, but it's all of the implications for the system when people send it back and then there's a red flag from it." And I was like, "That's literally the point why I'm doing this." But of course, the system has to try and cost those implications, and we forced it through, and it happens, and I hope it saved lives. But the ramifications for the system of picking up very early stage pancreatic cancer, which then requires Whipple surgery to pull it out, are obviously significant, and there's cost to do that. And as you say, is the system set up to do that and to have the implications of early stage disease. I'm not sure it is right now. So I think.
Well, it is and it isn't. So I have health insurance. I'm prosperous. I can pay for all of these things. And I am going to benefit from this science enormously. And the wealthy who can afford that kind of system support, you're going to see them living forever. I'm going to spot my cancer incredibly early and nail it, I think, I hope. What's more difficult is how do you then commoditize that and make it affordable for population-wide rollout as part of a socialized health system? Now, that is really important to be able to do. But what I worry about is whether there is either a cultural reaction against this kind of different way of doing things or a innovation bottleneck about just turning new science into applicable, affordable treatment pathways. I mean, the BMJ reaction to it would seem to indicate that there are some big problems in the way that we are going about innovation that are really regretful and will lead to massive health inequalities or additional health inequalities.
Well said. Right, last item. Of course, none of this early detection should get in the way of good exercise and that being moving. So Parkrun has now registered, believe it or not, James, 10 million participants in the UK. 10 million people who on a Saturday morning put on their trainers, get outside and spin around the 5K. Are you a park runner, James?
Yes, of course I am, Steve. You make it sound as though this is some kind of
silly me.
Extraordinary, weird cult thing that is marginal. Steve, loads of the country
marathons, though, haven't you?
It is
done marathons.
Literally the most successful and totemic civic engagement on activity in the whole of the UK. And it is a bit niche and it is a bit Waitrose, but it gets into all sorts of communities up and down the country. I'm a big fan. My big challenge with Parkrun is that I have now 3 children who run it faster than me, which is unbelievably annoying. And I've got one left and he's only 10, but he is nudging me.
Yeah. No, I mean, of course you are a park. Silly question, silly of me. But you've also done marathons. So the thing is about parkrun is that, here's my shameful confession is that I did start doing parkrun. But the thing is, you see, when you do it as an MP and you're looking like a horror and, you get to the end of it and I'm absolutely all out after 5K because I'm not a great runner. I used to do cross-country running actually when I was younger because I was tall and skinny then. But people will come up to you and say, "Oh, can I just ask you about X or this new planning application?" You're just like, literally can't breathe right now. So I did start doing it. And then after I left Parliament, I started doing it a bit more regular on Saturday morning. And my teenage boy used to come with me. And then he decided that he didn't want to do it and he'd hold the dog while I did it. And you know what? No matter how hard I tried, no matter whatever I listened to, how much I tried to pace myself, I just cannot get under 28 minutes.
That's fine.
I don't think that's. I think it's rubbish. 28 minutes, but I just can't get under it. Am I missing the point?
Totally.
Well, it's all about taking part.
28 minutes is brilliant. Congratulations. I thought you were going to say a number beginning with 3, so that you're completely outperformed. And then, secondly, from a health point of view, listen, you got your heart rate up. That's what a lot of this is about. Getting your heart rate up for half an hour once a week has all sorts of benefits to your health. And you should definitely, I mean, that's a great basis. And if you do a bit of gym during the week, a bit of stretching, a bit of weights, you will be down to 25 minutes in no time at all. But really, you shouldn't worry about that time. That is brilliant.
Yeah. No, I don't like getting lapped.
Who cares?
I keep getting I get lapped by the people who finished it. Yeah. Anyway, no. Okay, thank you, Dr. Bethell. I will try and get back to parkrun. I'd quite like to take Monty, my Labrador, but lots of people take dogs, but they always seem very well behaved.
So different park runs have different rules. Quite a lot of them now you can do the dog on a lead. So I take Tilly, but it's got to be a short lead.
Yes. The thing is about Monty is that he's so bad on the lead.
Well, then don't take him.
But I see people doing it pushing double push chairs. And I think, my God, this is hard enough. Anyway, well done to Parkrun. 10 million participants. I'm sure there's one in your community as you listen to this. And that is the end of you listening to this because this is the end of our episode, James. You can email us, preventionisthenewcurepodcast@gmail.com, and many have. Thank you very much. And you can find us on all the usual social media channels. Love to hear from you. Thank you. Please keep doing that. Please keep commenting. We'll read them out. And we'll see you next week, live episode at Rewired at the NEC in Birmingham. And that'll be going out next Thursday. I will see you for lunch, James.
Really looking forward to it. Who's paying, by the way?
Yeah, I don't know.
We'll hang over that at the time. Brilliant. Take care.
Bye.